Greetings and welcome to the first annual INPCS State of the Science Talk. I'm Darin Zahuranec from the University of Michigan. I'm the co-chair of the INPCS Science Committee, and I'm delighted to be joined today by my colleague, Dr. Claire Creutzfeldt from the University of Washington, who is the chair of the INPCS Science Committee. Now, our goals for today are to highlight some neurology-specific palliative care research, and our hopes are that this will inspire you in your own research and clinical practice. Now, a few notes on how we're going to do this today is that we're really just focused on some recent studies from the last few years. And while there are some great general palliative care interventional studies that have been done, we're really focused on those that are neurospecific. This is not really a systematic or comprehensive review, but really Claire and I went through some studies and thought there were several that we really wanted to highlight to make people aware of. We would, of course, welcome any comments from authors or anybody involved in these studies during the discussion period that will be occurring later. And so at this point, I'm delighted to turn things over to Dr. Claire Creutzfeldt to talk us through the first study.
Yeah, our first study was by the group around Dr. Kluger, and this was a randomized controlled trial. The cohort was patients with Parkinson's disease and related disorders and their caregivers. They were referred by other clinicians to this multidisciplinary clinic and were also assessed. Their needs were assessed, and then they were included based on their needs, and then randomized into either standard care group, which was a primary care provider. They made sure someone had a primary care provider and a neurologist, and this multidisciplinary clinic called Outpatient Integrated Palliative Care, which included, for starters, at least 2-hour visit with a palliative care clinician, a neurologist with palliative care training, nurse, social worker, and chaplain. And then they were also followed, and the primary outcome was patient quality of life and caregiver burden at 6 months. People were followed up to 12 months. This study showed improved outcome both from a patient quality of life perspective. As you can see in the left panel, you see the intervention group in blue above. Patients through those 12 months, even though it lost significance at the end, patient had improved quality of life in the intervention group compared to control. And then on the right panel, you see the caregiver burden measure that was also lower, so improved in the intervention group compared to control. So this was a really nice study, also really nice to read. And a few things that I just wanted to highlight here were that it was funded by PCORI, which also meant it had to abide by certain PCORI rules. It was a pragmatic clinical trial. It had patient and caregiver input. And I also really like that the intervention wasn't scripted. So people really went to this multidisciplinary clinic and their needs were met based on what these individuals needed. I think that non-scriptedness might be one of the problems, which is one of my question marks, is this scalable? So there was a more than 2-hour multidisciplinary intervention, and everybody got a different treatment. And so when I think about having to approach my hospital CEO to tell them this is what I would like for my patients, I worry that the hospital CEO might say that improved quality of life and caregiver burden might not be enough to implement that. And then the other question mark was the, which I think would be wonderful to discuss with the authors as well, is whether there are any ongoing efforts to include a more diverse cohort. More than 90% of the patients and caregivers in this study were white.
Yeah, Claire, unfortunately, that's a common problem in many clinical trials that, that there's a lack of diversity in the sample. And you know, a lot of people are doing really important work to try to make sure that our future trials involve more diverse populations so that we can be sure that they're applicable to everyone. That's going to be very important moving forward.
Yeah, and is a challenge for all of us.
Absolutely.
Exactly.
Absolutely. So we'll move on to the next study that you're going to talk about.
Yeah, this was also a randomized controlled trial of a palliative care intervention. This was done in England, and the cohort here was one of patients with long-term neurological conditions, mostly multiple sclerosis and Parkinson's disease. And these people were also referred by neurologists to this trial, and were included based on severity and sort of advancedness of their illness. And then they were randomized to standard care, again, primary care provider and neurologist, and then this intervention, which they called short-term integrated palliative care. I do think it's important to mention that it was short-term. The intervention lasted up to 12 weeks, an average of 3 clinic visits. And it started with a standardized assessment that seems scripted, looking at the supplemental material, where the needs of the patient caregiver were assessed, and then a plan was made and recommendations made to other clinicians. And then the outcome was patient symptoms at 3 months. And this study showed no significant difference between control and intervention. They did show actually a sort of an improvement in symptoms in the intervention group, comparing enrollment to 12 weeks, but there was no significant difference in the comparing the intervention group with the control. And I think I have, something I liked, or the things I liked. You know, one thing that I think the authors mentioned as a limitation, but I really liked, was combining a group of advanced neurological diseases. And one thing that I liked and questioned at the same time was this standardized assessment that seemed a little maybe inflexible to me. It seemed sort of maybe not as individual. So I liked it because I think it might be scalable, and someone else might come and say, oh, I can use this in my clinic. I question it because I wonder whether it is individualized enough. And then the other question mark I had was using these composite measures as primary outcomes. I always find really difficult. So a composite measure in this case was the IPROS, which measures a number of different kinds of symptoms and puts them into one number at the end. And so even if one symptom may have been improved, if another one wasn't, you might not actually see that difference.
Yeah, this was a really interesting study. You know, Claire, we've talked about 2 studies now of outpatient palliative care interventions. You know, why do you think the outcomes might be so different across these, with one positive study and one showing, you know, really no difference in the outcomes?
Yeah, I think that's what I was thinking about as well. I think they're difficult to compare. I think the setting may have been a different one. I think the one we're seeing here, the short-term integrated palliative care trial, was done in England, where I think the system around palliative care is a different one, and there might even be more palliative care available for these people. Another one is the interventions. They felt different to me as a reader. Like, I wasn't a participant and I wasn't an author in these studies, but as a reader, I have to say that the intervention around the Dr. Kluge's group felt a little warmer and fuzzier to me than this one, than the English one. And then possibly also the outcome measurement was much shorter. So the intervention was shorter and outcome measurements were shorter in the English study compared to Dr. Kluge's study. So all of those, whether or not they made a difference, I don't know, but those were thoughts I had.
Yeah, it'll be interesting things to think about as we move forward and try to find the best way to do this. So I'm going to move on and talk about another study now. This is a study by Dr. Pawson and colleagues. This was looking at the effect of a collaborative dementia care intervention via telephone and internet. And this was a really fascinating study. What they did is they started by enrolling people with dementia and their caregivers, and they randomized them to either a standard of care intervention or what they called a care ecosystem model. And the care ecosystem model was a telephone or internet-based collaborative care. I'm going to go through some of the details of exactly what they did in a moment here. The standard of care intervention group really just got some general resources and a quarterly newsletter. And then they followed these individuals up for 12 months and looked at patient quality of life, patient care utilization, and then also looked at caregiver depression and burden. Now, I really want to highlight a few features of the intervention in this study. I just think there are some really intelligent aspects of this intervention. So one is that this is administered through a centralized system, all by telephone and internet. And so this is actually completely independent of the healthcare system that the patients were ordinarily seen in. So they continued all their usual care for their regular doctors. The intervention was primarily administered by a trained care team navigator, along with a social worker, pharmacist, and advanced practice nurse. So there was really no direct physician involvement in this intervention. So the fact that they were able to administer this remotely and not need a physician to be directly involved, I think really enhances the potential scalability of this intervention. Now, these care team navigators underwent specialized training and had a standardized protocol of topics that they would review with the dyads on these scheduled calls. The calls occurred about once a month over the course of the year. The other thing I really liked was that this intervention was actually available in multiple languages. So we talked about issues with diversity in clinical trials, and this was certainly an effort to try to make sure this is applicable to people of different backgrounds, where the intervention was available in English, Spanish, or Cantonese. Now, in terms of results, they enrolled 780 people with dementia and their caregivers. Now, the statistics get a little bit complicated here, so I'm just going to summarize the broad strokes for space and time. But essentially, they found that at 12 months, the intervention resulted in notable improvement in patient quality of life. They reduced patient ER visits and reduced caregiver symptoms of depression, as well as caregiver burden. Now, some of the other outcomes they looked at, like patient hospitalization and ambulance use, weren't statistically improved in the intervention group, but the direction was towards improvement. And caregiver self-efficacy was another outcome that they looked at that actually was better at 6 months, but was not sustained at 6 months. One of the things that I really liked about this paper was that even though the statistics were a little bit complicated with a linear mixed effects model, where they could, they made an effort to try to translate their results into a number needed to treat that really makes us better able to understand the size of the impact of this intervention. And so when we look at the number needed to treat for patient ER visits, they would have to treat 5 patients with this intervention to be able to prevent one ER visit. And in order to prevent one episode of moderate to severe depression in a caregiver, they would have to treat 12 people. And if you think about some of the numbers needed to treat for other things that are really a well-accepted part of daily medical practice, these are really pretty impressive effects that we see here. Now, just thinking overall about some things that I liked, I really liked the design, that this was all telephone-based, very scalable, independent of the health system, did not have direct physician involvement. So I think this is something that really could potentially be ramped up to a large number of people. Now, one important limitation of this study that the authors noted was that they felt that they did not necessarily specifically target a high needs population. They said that, they didn't really say that there was going to be any possibility of direct benefit during recruitment. And so they were concerned that maybe some of the people who agreed to participate in this intervention were not really enrolling because they wouldn't have wanted to been put in a control group.
It's interesting that you say that, and I would guess actually that the fact that they didn't pre-select by needs might even be a a plus, because I imagine that selecting a cohort with particularly high needs is more likely to show a benefit with a sort of palliative care specific intervention. Don't you think?
Yeah, I mean, certainly, right. If you're not selecting a high needs population, it might be harder to show a difference. So that maybe just speaks to the robustness of this intervention. It's always an important public health issue that you're thinking about when you're trying to improve the health of a population. Do you, really just narrowly target the highest needs, highest risk group, or do you try to do something that's broader to improve the health of everyone? And so really important questions to think about. So going to move on to the next study here. This is one I'd like to highlight that was just published earlier this year by Dr. Bonner and colleagues. And this was a study of advanced care planning for African-American caregivers of relatives with dementia. So again, another randomized control trial, but this was specifically focused on African-American caregivers. Now, it's well established from observational studies that in US minority populations, they're less likely to complete advanced directives than the majority group. And given the importance of the church in many African-American communities, this group opted to deliver an educational intervention through the churches. Now, one aspect of this trial that is different from some of the others that we've looked at so far is rather than randomizing individuals, because their intervention was delivered at the church level, they actually randomized the churches. And so this is what we would call a cluster randomized trial. So they recruited participants from the churches and randomized into the intervention group, got a 4-week series of educational classes focused on dementia end-of-life treatments like CPR, tube feeding, and also on advanced care planning. The control group received a similar series of in-person classes on more general health promotion topics. And then the control group at the end of the study, after they collected their outcomes, they did get some information on advanced care planning. And they assessed outcomes actually in person at 4 weeks and 20 weeks. And they had measures of knowledge, caregiver self-efficacy, intention to make a care plan, and also whether they had actually completed a care plan. Now, they enrolled a total of 334 caregivers across the 4 churches, and they had retention of actually 87% at 4 weeks and 74% at 20 weeks. And so again, this is recruiting from the community, required in-person assessments. I think for this type of study design, that's actually pretty good retention. And they looked at outcomes, looking at a change from baseline to 4 weeks and then change from baseline to 20 weeks. We're going to focus on the 20-week outcomes here. Again, there's a lot of data here, but just in broad strokes, if we look at the results on knowledge scores, they did show improvements in knowledge of dementia, knowledge of CPR, mechanical ventilation, tube feeding, and actually also showed improvements in caregiver self-efficacy. Now, it was a little disappointing that these improvements in knowledge and self-efficacy didn't actually translate into the other outcomes. So in terms of a behavioral intent to complete a care plan, there was actually no improvement. And there was actually no improvement in the number of caregivers who had actually made a care plan for their loved one with dementia. The number of people who actually made a care plan was less than 15% in both groups. Now, again, what I really liked about this study was their focus on addressing an important health disparity. And using churches as a way of delivering the intervention has certainly been successful in other health promotion efforts and cancer screening and things like that. And so this may be a design for other palliative care researchers to consider in the future. Something I didn't like quite as much, I was a little disappointed the improvements were really only in knowledge and self-efficacy, but really didn't see any improvements in the actual number of people who completed a care plan. And maybe 20 weeks wasn't enough time, or maybe they needed to, tweak their intervention to have a little bit more details on how to complete the care plan. Maybe the authors, if they're around, could comment on that in the discussion time. But despite these limitations, I think that this is just a really important example of the kind of work that can be done, working within a community to try to address health disparities. And I'd love to see more work along these lines in the future.
Thanks, Darin. I had 2 comments or questions. One of them was the high retention rate, and I was wondering if that may have maybe sort of a selection bias, because I imagine people joined because they wanted to join.
Yeah, I think certainly, that it probably was a motivated population. But still, they had to come back for in-person classes every week. And I think that, they use the pastors, and they use the pastors in the recruitment. And so this is, I think, also speaks to the power of that. If the pastor says, this is an important thing to do, and they endorse it, I think that can really help with the retention when you do this type of work.
Yeah, cool. My other thought or question was whether the outcome that was negative was the right or best outcome, because I think maybe people still felt better about their care plan and they just didn't change it. And I wonder if measuring something like that, something more maybe not patient-centered but participant-centered, might have shown an effect.
Yeah, it's interesting. Certainly, maybe they were better educated and decided that no, they didn't want to write a care plan, and that wasn't right for their family. So that may not necessarily be a negative. It's hard to tell from this, but that's an interesting perspective. So, all right, we're going to move on and just briefly discuss one last study. This is from Dr. Mason and his colleagues from the UK. And most of you may know that Claire and I are both stroke physicians for our clinical practice, so we had to put at least one stroke study in there. Now, this is not a randomized trial, but actually an effort to try to develop an understanding of what outcomes we should be using in future studies of stroke palliative care interventions. And this group got together experts in stroke and palliative care, but it's really important that they also included patients, caregivers, and bereaved caregivers in this process of trying to understand the best outcome measures. They started with the literature review and then used a method called a Delphi survey, which is basically an iterative set of surveys allowing individuals to vote on the importance and usefulness of different potential outcome measures. And this is really an established method for building consensus amongst a group of experts. Now, I'm not going to go into the details of which particular outcomes they recommended, but I wanted to highlight this work for two reasons. And one is that those of you who are considering projects in the stroke palliative care space, I think this would be good to look over this article and think about the list of outcome measures. And also to highlight this method of collaboratively building consensus with both, content experts and stakeholders in the caregiver and patient space to try to think about whether you may want to use similar methods in your own specialties to try to establish consensus on the most important outcome measures.
Yeah, maybe fitting to what we were just talking about with this prior trial is that agreeing on the outcome that you want to change is important, and so finding consensus is challenging and important.
Yeah, looking at the list of outcomes, I don't know if I'm convinced that this is the final list of the best outcomes for palliative care and stroke. I've talked with you and other people about this. I think this is still an area where we all have a lot of work to do, but I do think that this study is a really important step in the right direction for this. So in closing, we want to remind you of a lot more research that's going on in neuropalliative care. And we hope that you've already seen and will continue to look at, review a lot of abstracts that are on this meeting site. And you can look at them at your convenience. They are, most of them even with audio, and they represent a really broad perspective of neuropalliative care research. Today, we just wanted to highlight the 4 top scoring abstracts. So we have Dr. Amber Comer, who's presenting an abstract on goals of care after severe stroke. Dr. Stephen Miranda has an abstract on serious illness communication in glioblastoma. Dr. Lourdes Kahua-Poma is talking about health-related quality of life in the MISTY trial, so after intraparenchymal hemorrhage. And Dr. Erica McKenzie has an abstract on healthcare utilization in Parkinson's disease at the end of life. And with that, we'd like to move over to Dr. Anna Maria Vranciano, who will introduce our 2021 INPCS Outstanding Scientific Contribution Awardee. Thank you very much.